So without further ado, I'd like to introduce Dr. Andy Rhim from the University of Michigan. Andy runs the Pancreatic Cancer Center at Michigan and previously had been at Penn, focus obviously in pancreatic cyst lesions. So with that, Andy, over to you.
Thanks, Rhim. I'd like to thank Rhim and the folks at RainDance for the opportunity to share with you some exciting data, some of our very recent personal experience using Thunderbolts to assay ultra-low input, to perform ultra-low input target analysis for pancreatic cyst lesions. So our laboratory is interested in understanding the biology of early pancreas cancer with the hopes of using this knowledge to come up with better ways of achieving earlier diagnosis of pancreas cancer and hopefully impact treatment. Now, there are two different precursors to pancreas cancer. The first is pancreatic intraepithelial neoplasias or PANN lesions. These can lead to ductal adenocarcinoma, but they're currently undetectable using current clinical assays such as CT scans or MRIs. So here the problem is detecting the PANN lesions in the first place. But the opposite is true for the second type of major precursor to pancreas cancer, which are pancreatic cystic lesions. And here we're focusing on intraductal papillary mucinous neoplasias, or IPMN lesions. These lesions can lead to cyst adenocarcinomas or ductal adenocarcinomas. But with these lesions, because of the fluid-filled components, and because they usually present a little bit larger, 0.5 centimeters to 3 centimeters, they're readily detectable on CT scans and MRIs. The problem here is that IPMN lesions are being diagnosed at a skyrocketing rate. With every person that gets a CT scan or MRI, we're finding incidental diagnoses of IPMN lesions, such that we now diagnose IPMNs in about 1 in 1,000 Americans over the age of 60. And this is a clinical conundrum because only a small portion of these lesions will go on to develop pancreas cancer. But if we can catch these lesions early enough, we can prevent cancer from forming in the first place by performing a pancreas resection in the form of a distal pancreatectomy or a Whipple procedure. But these procedures are very complex surgeries associated with complications and morbidity. Many patients after this surgery will develop brittle diabetes or malabsorptive disorders. Now, clinical guidelines do exist that let us know which patients we should be referring for pancreas resection. These criteria are called Sendai criteria, and they're basically a consensus opinion of a panel of experts. On balance, there's very little clinical data for its use, but it's the best thing that we have so far. These criteria basically are based on the radiographic appearance of these lesions on CT or MRI and cytopathologic analysis of the cyst fluid. But these criteria are fraught with problems. First, we know that these criteria have very poor sensitivity. Of all lesions that are Sendai criteria negative or thought to be benign, we know that about 10% will go on to develop cancer. But even more worrisome is the fact that these criteria have very poor specificity. So of all IPMN lesions that are resected based on Sendai criteria, only 60% will have dysplasia or invasive carcinoma on the resected cyst. That is to say, about 4 out of 10 patients may be getting their pancreases cut open for no good reason. So we need to develop better ways to predict which IPMN lesions will go on to develop into cancer. And we've been encouraged by recent data from the Vogelstein and Kinsler groups, in which they've been able to show that the presence of a mutation in KRAS and GNAS are highly associated with advanced pathology. And the question that we've been asking in the laboratory is, can we use this information now to predict which IPMN lesions will have invasive or dysplastic pathology in real time prior to the decision of surgery? But there are many obstacles in the genetic analysis of cyst fluid. First, the sample is extremely limited. A 1 centimeter lesion will typically yield about 1 milliliter of fluid. And most of this fluid is already spoken for. So based on Sendai criteria, we have to send out all specimens for 2 tests. A cytopathologic analysis, which comprises about 0.5 to 1 milliliters of the fluid, and another 0.5 to 1 milliliters for tumor marker analysis. So it leaves very little in the way of extra sample for us to be able to do clinical trials to see whether or not some of this technology can actually work in the clinic. Moreover, work from a collaborator at University of Michigan, Michelle Anderson, has shown that cyst fluid from the pancreas contains a number of PCR inhibitors that prevent optimal PCR reactions from moving forward. So these were the reasons why we turned to the Thunderbolts, and I won't go through all the reasons why we decided to turn to Thunderbolts, except to say that sample inputs was the main reason why we wanted to use this technology. So we performed a pilot genetic analysis of cyst fluid. This is data driven mostly by my postdoc, Angelina Landana, who's in the audience. And here the hypothesis is very simple. Can we find a genetic signature in less than 10 microliters of cyst fluid that can distinguish between benign and advanced pathology in resected cyst lesions? Can we beat the current clinical criteria today? So we analyzed 5 cyst fluid samples from patients who eventually underwent pancreatectomy. We loaded 10 to 50 nanograms for analysis, and we confirmed mutations using droplet digital PCR using TaqMan chemistry, as was discussed before. And then we compared the genetic signatures to resulting pathology that was found in the resected pancreas. So here are the standard quality data. These are the 5 samples, and sample 2 has as little as 8 nanograms of DNA. And no matter if we look at the 50 nanogram input or the 8 nanogram input, we get very similar data. We get very uniform coverage of the sample, and we get very deep coverage at that, with almost all samples achieving 200x coverage with the Thunderbolts-enabled sequencing. What about mutation calling? So here we see the 5 individual samples organized in terms of pathology. So if you look at 4 and 5, these are the cyst specimens that had normal or benign pathology. We didn't find any mutations. Well, if we focus on samples 1 through 3, which had invasive carcinoma or dysplasia, now we begin to see that all these samples have detectable KRAS and GNAS mutations. Moreover, we find additional mutations that have been annotated previously but of low penetrance in the population in the sample with invasive carcinoma. We were able to validate these mutations using droplet digital PCR with TaqMan chemistry, and shown here are raw data validating this. So here we're looking at sample 1 with the invasive carcinoma, and we find that 26% of all the KRAS DNA contain G12D mutations, whereas 0% of the KRAS DNA in sample 4 with benign pathology contained this mutation. So we were able to confirm KRAS mutations in all 3 samples in which we were able to find it in Thunderbolts-enabled sequencing. But what was really striking was the fact that we saw high concordance in the allelic frequency of the KRAS mutations, whether we used MiSeq sequencing data or the TaqMan assay. And finally, we compared our data to a currently widely used send-out test at a clinical laboratory that specializes in the detection of KRAS mutations in pancreas cyst fluid. And what we found was that this send-out laboratory was only able to find KRAS mutations in 1 of the 3 samples in which we were able to find KRAS mutations using 2 complementary technologies. So in terms of future directions, we're really excited with this product because we're getting quality data off of very difficult patient specimens. But this Thunderbolts panel, while great, is missing some of the mutations that we would like to be assaying for. So we're working with RainDance in customizing a Thunderbolts panel to make it a pancreas-specific panel at that. And once we have this panel, we have buy-in to perform a clinical trial to test the clinical performance of Thunderbolts-enabled sequencing, as well as a targeted mutation assay for KRAS and GNAS mutations, and compare them to send-out criteria. So I've shown you data to suggest that Thunderbolts-enabled targeted sequencing can be done with as few as 8 nanograms input DNA from a very difficult specimen, pancreatic cyst fluid. And we're able to show that KRAS and GNAS mutations do indeed correlate with the presence of worrisome pathology in cystic lesions, now allowing us to launch into a clinical trial. So with that, I thank you for your attention, and I think we're taking questions later on or right now? Later on. Okay, thank you.